In our discussion of hematology today, we are going to talk about anemias. Now, anemias, there are a lot of variety of anemias, various types of anemias. Today, we are going to tailor our discussion to the hypoproliferative anemias. Before going into the details, it is very important to understand that anemia itself is not a disease. It is rather a symptom of a disease. And there are a lot of diseases which can lead to anemia. So whenever we find a low hemoglobin count or anemia in a patient, it is very important to investigate what is the underlying cause. Hyperproliferative anemias are classically defined as the anemias which are accompanied by the normochromic normocytic RBCs along with a decreased reticulocyte response as expected. Generally, the reticulocyte response is around 2.5 to 3 is considered normal, or anything above 3%, greater than 3% is considered normal. But if the reticulocyte response is less than 2%, then that is classically, and if it is accompanied by a normocytic normochromic anemia, then it is classically defined as a hyperproliferative anemia. The major anemias which come in the hyperproliferative anemias are the most commonly are the early stage iron deficiency anemia. As we all know that iron deficiency anemia initially presents as a normochromic normocytic anemia, and later on, if the iron deficiency is prolonged, it transforms into hyperchromic microcytic anemia. So an early stage of iron deficiency anemia along with the decreased reticulocyte response is classified as a hyperproliferative anemia, and it is the most common cause of hyperproliferative anemias. Other than the iron deficiency anemias, other types of disorders that can lead to hyperproliferative anemias are the acute or chronic inflammation, primarily the initial stage of the acute or chronic inflammation, chronic kidney disease, or other hypometabolic states, and anything that leads to bone marrow damage over a long period, like myelodysplastic syndromes. We're going to talk about the iron deficiency anemia in detail here, and later on in the latter part of the lecture, we are going to describe briefly the other types of disorders that can lead to hyperproliferative anemias. Now, as we all know that iron is very important for the normal regulation of the body systems. We require the major function of iron is to be incorporated into the hemoglobin and to carry out oxygen from the lungs to the various parts of the body. Along with that, iron is very important in regards to the electron transport chain, as the various components of the electron transport chain in the mitochondrial matrix and the mitochondrial membrane require iron for their normal functioning. So anyone who is deficient of iron will not have normal oxygen transport, and along with that there will be inadequate production of ATPs because of disruption of the electron transport chain. The body very strictly regulates iron because any increased quantity or toxicity of iron can be very hazardous for the body. And in fact, there is no regular mechanism of the release of iron or the excretion of iron in the body. The major pathways via which the iron is excreted from the body are either from the bleeding, via GI tract, or from the menstrual cycle in the females, or via the regular shedding of the epithelium of the gut or intestine. This is which is the normal turnover of the epithelial cells. Iron is not secreted in the urine, it is not secreted in the feces. So that's why it is very important for the body to regulate iron strictly, because of a lack of proper excretion mechanism, unlike the other cations or anions. Here I am going to show you a picture of iron deficiency anemia. Here you can see certain RBCs which are of normal size. Here, when the whole extent of the RBCs is filled with the hematocrit, this is a normochromic RBC here. Along with that, whenever there is increased area of translucency, like in certain RBCs here, this is a hyperchromic picture. So iron deficiency anemia initially starts off as a normochromic or a normocytic anemia. But later on, if the anemia is prolonged, then it is transformed into a hypochromic or a hypocytic anemia. Hypochromic means that the chromasia or the hematocrit present, it decreases, and hypocytic means that the size of the cell also shrinks. Iron deficiency anemia is the most common metabolic deficiency in the world, disorder relating to the nutrition, and it is very imperative, especially in the third world population, but it is also increasing worldwide in the developed population as well. Iron is vastly available in meats and other products. Iron deficiency anemia can develop in the strict vegetarians if they are very strict with their diet, and it can also develop if there is a lot of underlying bleeding and we are not aware of the pathology. In fact, in females, generally the iron or the hemoglobin concentration, which is a marker of iron, is generally low from the males because of the hormone regulation of estrogen compared to the testosterone. Testosterone leads to increase in the erythropoiesis, which utilizes iron. That's why males generally have a higher iron content as compared to the females. So to understand the iron deficiency anemia, it is very important to understand the basics of the iron metabolism. When we orally take the foods containing iron, if the food which we are taking is, for example, red meat or something which is very high in iron content, a lot of it is absorbed and it moves into the circulation. But certain foods which have low iron content, a small portion of the food of iron is absorbed from those foods. So whenever we orally take iron, it moves into the enterocytes. After moving into the enterocytes, it goes into the blood plasma. From the blood plasma, it is the iron is bound by soluble protein called transferrin, which is produced in the hepatocytes. Transferrin, as the name indicates, transfers iron, transfers ferrin. So it is basically, you can understand, you can think of transferrin as an iron binding protein, in which form iron is transported across the blood. Iron does not move as a soluble product, or it does not move on its own. It needs some protein to carry it from one part to the other. So the transferrin carries the iron transfers the iron from the enterocytes, or whether the iron is being produced from the rapid turnover of the aging RBCs, as we are going to see, and it transfers it to the bone marrow. And in the bone marrow, the RBCs or the erythrocytes, they take up the iron and then they combine the iron with heme and form hemoglobin. So hemoglobin is the major product, and afterwards this hemoglobin is incorporated into the RBCs which are being produced from the bone marrow. And so the iron which we take in the dietary form basically moves in the blood in the form of RBCs, and that RBCs iron can only be utilized when the RBCs die. So from the bone marrow, the iron gets transported into the RBCs. And along with that, when the RBCs age, then the reticuloendothelial system, which comprises of the macrophages of our bone marrow, liver, spleen, and the other lymphoid organs, they are the ones which, when an RBC lives through his age, which is generally about 120 days, we term it as a senescent or an old RBC. And when it is broken down, the iron and the globin chains are separated. The globin chains are recycled for the production of the hemoglobin, and the iron is released again, which binds the transferrin, and the whole cycle is repeated again. So this is the whole cycle of iron metabolism. Along with that, from the blood plasma, iron can also be moved to the other tissues for which carry out the daily requirement. For example, the major tissue involved here are the hepatocytes, which require iron to be incorporated into various enzymes. So after this picture, the iron excretion pathway, as I told you, there is no proper excretion pathway for iron secretion. The only way iron can be secreted from the body is either the regular shedding of the epithelium via the gut or the intestines, and along with that, if there is any bleeding in the gut, or in case of females, from the regular menstruation cycle. The same point is explained here in the sort of a diagram. Let me just play the diagram first, and then we are going to explain it step by step so that you have a better understanding of what is going on. So we start off here at the level of transferrin. Transferrin iron is the one which is taken up by the gut. So we take up iron in the form of the food. It moves from the small intestine at the level of the duodenum, proximal duodenum. It moves into the enterocytes, and it is transported by a divalent transporter. After inside the gut, iron can either be moved onwards from the enterocytes to the blood, or it can be stored in the enterocytes in the form of ferritin. In fact, when we have a turnover of iron in the erythrocytes, there is a deposit of iron in the form of ferritin as well. We are going to talk about it in just a minute. So for the iron to be transported from the enterocytes to the blood plasma and combined with the transferrin, we need certain transporters. These are basically termed as ferroportin transporters, which are present at the basolateral side of the enterocytes. And these ferroportin transporters are basically kept in check by a product called hepcidin. This hepcidin is produced by the liver, and it basically gives a feedback or mechanism of iron transport from the enterocytes to the plasma. This hepcidin level is regulated by the body iron levels. So whenever there is an increased demand of iron, for example, in cases of iron deficiency anemia, the hepcidin generally the general function of hepcidin is chronically inhibiting that ferroportin transport, so that only the iron which is required by the body is released from the enterocytes, and the rest of it is stored in the ferritin in the enterocytes. But when there is an increased demand of iron, for example, in cases of iron deficiency anemia, hepcidin level generally is downregulated by the liver, and a lot of iron is being absorbed from the enterocytes. So that is why it is this regulation, strict regulation, is very important and keeps a good check on the iron levels in the body. So from the gut, we absorb the iron. Iron moves into the plasma, and it is combined with transferrin, which is a transfer protein of iron. This transfer protein is in synchrony with the parenchyma of the liver as well. It transports some iron to the liver, and iron can also regulate it with the help of transferrin. And if there is certain extravascular exchange from the level of the cells, and the iron which is being broken down by the reticuloendothelial system, the reticuloendothelial system which breaks down the old RBCs, the iron released from those old RBCs is also taken up by transferrin iron. So the the iron present in plasma is all bound by the transferrin. There is no free iron in the plasma because it is very highly toxic, and iron can lead to the production of free radicals if it is freely available. So from the transferrin, iron is transferred to the erythrocyte bone marrow. Here the RBCs, the erythrocytes, they take up the iron. Iron is important for the heme metabolism, for the production of hemoglobin. Iron combines with the protoporphyrin in the last step of production of hemoglobin in the erythrocytes. And after the combination of protoporphyrin and iron, hemoglobin is being produced. And that hemoglobin then moves in the RBCs, and that iron basically transports in the plasma in the form of circulating erythrocytes. And later on, when these erythrocytes have lived their life, they are taken up by the reticuloendothelial cells. Similar to what happens in the gut, if we have an excess of iron in the erythroblasts or the erythrocytes, that excess iron is stored in the bone marrow in the form of ferritin, which is the storage pool of iron. So whenever we have iron deficiency, or for example in states where we require excess of iron, that ferritin pool of iron, which is basically a large storage depot of iron, it can be mobilized, and as long as that ferritin pool compensates for the iron requirement, we won't have iron deficiency anemia or symptoms of iron deficiency. The parameters of iron indices, the transferrin saturation, transferrin, and the total serum iron will remain normal as long as that mobilization pool or the storage pool is compensating for the loss. But if in states of excessive iron deficiency which is not being compensated by the diet and the storage pool gets depleted, we will have stage-wise symptoms of iron deficiency. So it is very important to understand these basics so that moving forwards we are going to understand what are the various indices, how do they signify the iron metabolism. All right, let's just talk briefly about the body iron distribution in regards to an adult male and an adult female. There are two major differences in the males and the females in regards to iron management. The number one thing is the hormonal differences. Males have testosterone, females have estrogen. Testosterone is generally an effective erythropoiesis, leads to effective erythropoiesis, or leads to an increased production of RBCs. That's why males generally have slightly larger hemoglobin levels as compared to the females. Secondly, there is a cyclical loss of iron in the form of blood in an adult female through the menstrual cycle, which the males do not have. So that these two contexts lead to general increased levels of iron or hemoglobin in an adult male. So the hemoglobin level, the iron content in terms of milligram in the hemoglobin in an adult male is generally 2500 as compared to an adult female, which is about 1700 milligrams. In the myoglobin or the other enzymes, in an adult male, the iron content is about 500 milligram, and in an adult female, it is about 300 milligram. All of these indices basically indicate that an adult male generally has a higher iron content as compared to an adult female. The transferrin iron or the iron saturation, it is the same for the both adult male and female, because all the iron which is present in the body and in both sexes is basically carried out by the transferrin. So there is no iron circulating in the plasma which is not bound to transferrin. And the iron stores generally are a bit higher in the adult male, which is about 600 to 1000 milligrams, as compared to an adult female, which is about 300 milligrams. So these basic differences are because of hormonal regulation and the cyclical regulation of menstrual cycle in the females. Now let's just talk about the iron deficiency anemia here in slight detail. Iron deficiency, as I told you, is the most common metabolic deficiency in the world, and it does not develop acutely. There are a few stages in which the iron deficiency develops. The number one stage is the negative iron balance. Negative iron balance, as the name explains itself, is when the total utilization of iron is more in compared to the demand of the iron. So the body is in a negative iron balance. The demand and supply are not meeting, and the demand is more but the supply is less. So that leads to a negative iron balance. And at this stage level, we don't have any clinical symptoms or any indices which indicate a negative iron balance. These can be the states in a normal person where there is a large requirement of iron which is not being compensated by a normal diet. For example, in someone who is an adult and he has a growth spurt, or if a female becomes pregnant, she has larger requirements of iron. Or if someone is bleeding, for example, if a female has menorrhagia or increased bleeding during menstruation, or if an adult male is slowly bleeding inside the gut and he does not have any symptoms yet. So these are the conditions in which the iron supply is basically not compensating for the demand, and the body requires a lot more iron. So what the body does, it starts utilizing the stored iron from the ferritin levels. From the ferritin levels, the iron starts moving into the plasma in the transferrin, carried to the transferrin, and then it is moved to the RBCs in the form from the bone marrow, and the erythropoiesis starts taking place. But this slowly leads to the depletion of the iron stores. And when we reach a stage when the iron stores are depleted, and when the iron stores are when the iron stores in the negative iron balance start depleting, the total iron binding capacity, or the transferrin saturation, the serum iron, all these indices are generally kept in check. Even the serum ferritin starts going down slowly, very slowly. Generally, a serum ferritin level is about 100 to 300 micrograms. It starts slowly going down, and until the serum ferritin level goes less than 15 micrograms, then that stage is termed as the iron deficient erythropoiesis. When the serum ferritin level falls below the 15 microgram threshold, that is a condition which we know that that those serum ferritin levels correlate with the body iron stores. So whenever the serum ferritin levels goes down below the 15 micrograms, that means that the body stores of iron have been depleted and there are no iron stores in the bone marrow. So serum ferritin is the best indicator of the body iron stores and the reserves of the iron. So whenever we have a serum ferritin stage going down below the 15 or 20 threshold, that condition is called iron deficient erythropoiesis. And in that stage, the body can no longer compensate for the loss of iron or the increased demand of iron unless iron is supplied in the form of diet. So that second stage is classified or defined as an iron deficient erythropoiesis. And if this stage continues, at this stage, the serum ferritin has gone down, the body markers start going down, the transferrin saturation has gone down, transferrin levels or the total iron binding capacity, it goes up, serum iron starts falling. But the hemoglobin level generally remains the same, more or less, at this stage. If this stage is prolonged, then slowly there is a slight decrease of hemoglobin, which hemoglobin starts falling from a normal of the 13 or 14 milligrams per deciliter. And once it goes below initially when there is hemoglobin level of around 10 or 11, there are not many symptoms. But when the hemoglobin level falls below the 7 to 8 milligrams per deciliter level, then we have this classic symptoms of iron deficiency anemia, which we are going to talk about in the coming slides. So this is a stage-wise deficiency of iron. Initially, the body goes into a negative iron balance. If that is not compensated by the diet, and if the demand goes on increasing or continues, then the body goes into the iron deficient erythropoiesis level. And if this deficient erythropoiesis is continued and we are not compensating or giving the body iron in the form of diet, then that eventually leads to iron deficiency anemia. The same thing is explained here in another pathway. In the stage 1, we have slowly the depletion of the iron storage in the liver, bone marrow, and the muscle. This is classically defined as a pre-latent iron deficiency. The serum ferritin level slowly starts going down, but the other body indices, the saturation or the transferrin levels, they are generally kept constant. When the serum ferritin level goes down less than 30 micrograms per liter, we classify it as partially depleted. And when it is less than 12 micrograms per liter, that is when we say that serum ferritin levels are fully depleted, which by convention means that the bone marrow storage of iron has been completely utilized. At that level, when if you're going to do a bone marrow biopsy and stain it for the iron, you won't find any iron in the bone marrow. In the stage 2, we'll have the depletion of the transport iron pool in the blood plasma. After the depletion of the storage pool, there is a depletion of the transport iron pool in the plasma. That is classified as a latent iron deficiency. And at that stage, we have the other indices apart from the serum ferritins, which start going down. Serum ferritin is already low. Transferrin, or the total iron binding capacity, the capacity of iron to be bound to transferrin, and the transferrin protein production is increased because this protein production is increased to compensate for that iron loss or the decrease in iron levels. And the last stage is if you don't compensate the iron requirement in the second stage, it eventually leads to a full developed iron deficiency anemia, and the hemoglobin levels start falling down. And this is classically evident by our CPC count, which shows decrease in the hemoglobin levels. Now, let's talk about the causes of iron deficiency anemia. The list is exhaustive. Let's break it down and talk about what are the most common ones. Iron deficiency can either occur if there is an increased demand of iron, or if the demand of iron is normal but there is an increased iron loss in any form, or either there is a decreased iron intake or absorption of the dietary iron. Let's talk about the increased demand of iron. What are the various stages, or what are the various conditions in which the body requires more iron? Either in a rapid growth spurt, for example, in adolescence age, there is a rapid growth spurt, and at that stage, the body demands more iron. Similarly, in a pregnant female, especially in the second and third trimester, it is very important to replenish the iron. We generally don't give iron in the first trimester because when the organogenesis is taking place, and iron can be toxic for the developing fetus. But once the a female moves into the second and third trimester of pregnancy, for the normal development of the cells and the developing fetus, iron depletion is very important, and all the females should be on iron supplements in the second and third trimester of pregnancy. So if there is an increased demand of iron in these conditions, and if that demand is not being met, that can lead to iron deficiency anemia. Similarly, if we are doing an erythropoietin therapy, then the erythropoietin leads to the stimulation of the RBCs. But if there is inadequate iron to balance that stimulation, we will have an iron deficiency anemia. Now let's talk about what are the conditions which can lead to increased iron loss. If there is a blood loss, either acute or chronic, in any condition, in the females, the menstrual cycle is the major way of them to get rid of the iron. And along with that, if there is any acute blood loss or hemorrhage, or if there is if someone donates blood to any other person, that can also lead to iron deficiency anemia. And if, for example, in conditions like polycythemia vera, we do a phlebotomy in which we remove the plasma, that can also lead to loss of iron. In fact, as a clinical pearl, whenever you have, you should always remember that whenever you have an adult male which is presenting with, or for that matter, a young male, presenting with iron deficiency anemia or unexplained iron deficiency anemia, the number one thing to rule out is a GI blood loss, because in the males, the most common cause of iron deficiency anemia is the loss of blood to the GI tract. So the number one thing to think about in case of anemia in a male is the GI blood loss or the blood loss in general. If there is a decreased iron intake or absorption, that can also cause iron deficiency anemia. For example, someone who is just not taking enough iron on a strict vegan diet, and that has inadequate iron supplementation. Or if someone who's taking a normal diet but has some malabsorption disease, for example, celiac disease or a sprue, which is leading to inadequate absorption of iron from the gut. Malabsorption can also be because of a surgical procedure which has reduced the gut, for example, in a gastrectomy or any other procedure that has led to compromise of the duodenum, and there is inadequate surface area for iron absorption. For iron absorption, iron should be move from the ferric to the ferrous iron condition, and for that to happen we need a good acidic condition in the duodenum. So in patients who have less gastric acid content, for example who are on chronic PPI therapy, or in someone who has had a gastrectomy, that decreased acid content of the proximal duodenum also interferes with the iron absorption at the level of the duodenum. So that can also present with malabsorption. And in cases of acute or chronic inflammation, the body just stores the iron in the ferritin because of an increase in the hepcidin production. We're going to talk about it in the discussion of chronic or acute inflammation. These are the broad lines of the major classification of iron. Either there is an increased demand or an increased iron loss, or either any problem with the gut, with the intake or the absorption. Now let's talk about the symptoms of iron deficiency. The general symptoms, if someone who has a GIT blood loss, that will lead to iron deficiency anemia. The patient will have fatigue, pallor, reduced exercise capacity. If someone who has been who used to exercise for 45 minutes very easily, the exercise capacity might be reduced to 20-25 minutes. They will feel lethargic, they will feel slow, dull. In advanced iron deficiency, the patients might have chelosis, which is fissuring of the corners of the mouth. And if the iron deficiency is continued, hemoglobin falls to very low levels, about 5 to 6. The patient might have koilonychia or spoon-shaped names, as evident in this picture. These are the general presentations, and these are the ones if we have a patient who presents with fatigue, unexplained fatigue, pallor, then we have to investigate for iron deficiency anemia, and we do a lab count. What are the important labs? Apart from the CBC, which gives us a good indication of the hemoglobin levels and the other RBC indices, for the iron deficiency anemia, the important labs to consider are we do a serum iron and the total iron binding capacity. The serum iron gives us a good indication of the total amount of iron content of the body, and all of this iron is bound to the transferrin. So it also gives us a good indication of that the plasma iron. It also gives us a good indication of the transferrin level. The total iron binding capacity roughly correlates with the transferrin production by the liver. The most important test is the serum ferritin level. The serum ferritin generally correlates with the ferritin levels in the reticuloendothelial system or the bone marrow or the storage of the iron. So whenever we have a serum ferritin which is going down, we can confidently say that our stores of iron are going down. The most important screening test initially, as it is the serum ferritin level, and then after the results of the serum ferritin level are available to us, we move on to the other investigations. We can complement the serum ferritin levels by the bone marrow iron stores evaluation with the help of Prussian blue staining, which stains iron blue. This has largely been overtaken by the serum ferritin levels, and if it is very much required to evaluate the bone marrow or take a bone marrow biopsy, then we only do these bone marrow studies. The red cell protoporphyrin levels are also a very good indicator, because as I told you, that in the last step of formation of hemoglobin, protoporphyrin combines with iron. So if there is iron deficiency, there will be an increase in the protoporphyrin levels, and in fact in iron deficiency anemia, the protoporphyrin levels go down because there is not enough iron for them to bind and form hemoglobin. So that also gives us a good indication. Along with that, serum levels of transferrin receptor protein. Now, this is a new test, and this is basically the context of this is whenever the iron has been transferred from the transferrin to the bone marrow or the reticulocytes or the erythrocytes, they utilize the iron bound to the transferrin and expel the transferrin outside to be recycled or reused. And along with the expulsion, there is certain transferrin receptor which are present at the basal level of the erythrocytes. They are also moved out. Most of them are being used by the cell again to recycle the transferrin receptor, but some of it is also secreted in the plasma. So this newer test of serum transferrin level protein, it has become recently very popular, and it is gaining more popularity with time, that it can also give us a good indication of the transferrin levels in the body and the utilization of the iron by the cells. Now let's talk about the differential diagnosis of iron deficiency anemia. As I told you that iron deficiency anemia initially starts off as a normocytic normochromic anemia. But later on, if the iron deficiency is prolonged, it can transform into a hypochromic microcytic anemia. So what are the differential diagnoses of the hypochromic microcytic anemias? The important tests which we are going to go through stepwise, the four important diagnoses of hypochromic microcytic anemia, and I want you to remember that the iron deficiency, which is the most common one. Afterward, anemia of chronic inflammation, which generally involves acute or chronic inflammation, or you can simply say it an anemia of chronic disease. Any chronic disease like a cancer patient or chronic tuberculosis or myeloma disease or any chronic inflammatory disease can lead to similar presentation. If it is long term, it can lead to a similar picture of iron deficiency anemia, and then we have to differentiate it on the basis of the labs. Thalassemia, which is the genetic disorder of a globin chain synthesis, it also presents as a hypochromic microcytic anemia. And then there is a condition called sideroblastic anemia, in which the iron content is available for the cells to manufacture iron, but there is not enough hemoglobin synthesis or synthesis of the protoporphyrin because of enzymatic regulation or down regulation at any level. There are various, and that leads to sideroblastic anemia. And it is called sideroblastic anemia because the iron which is available, it accumulates in the mitochondria and it forms a ring around the nucleus, which is called a and that RBC with the enhanced iron in the mitochondria is called a ring sideroblast. So from that context, it is classified as a sideroblastic anemia. There are various causes, certain genetic deficiency of the enzymes in the heme pathway, or for example, in the acquired causes, there is either lead poisoning or pyridoxine, B6 deficiency, isoniazid deficiency. So based on the cause, we treat the sideroblastic anemia, but it also leads to a macrocytic hypochromic anemia. So initially, or a smear, in an iron deficiency anemia, to start off, we have microcytic hypochromic anemia. We have normocytic normochromic anemia initially, but later on, with advanced iron deficiency, we will have microcytic hypochromic anemia. In the inflammatory condition, we might have a normal smear or a microcytic hypochromic anemia. So that is not very helpful in differentiating the two conditions. In thalassemia, along with the microcytic hypochromic picture, we might have certain target cells in thalassemia. So that can be helpful in the differentiation. While in a sideroblastic anemia, the picture is variable, we might have certain ring sideroblasts that will be helpful for identification, but they are not always present, and that is not very helpful in at the level of the smear. We might have to do a bone marrow biopsy to look at those ring sideroblasts. Serum iron levels in iron deficiency anemia are generally low. Normal serum iron levels are around 100 micrograms per deciliter, but in iron deficiency they can be as low as less than 30. In inflammation, the serum iron levels are generally low, but not as low as compared up to the level of the iron deficiency. They are around 50% or 50 micrograms per deciliter. In thalassemia, the serum iron will be perfectly normal or high, and similarly in sideroblastic anemia, there is no iron abnormality. So the iron levels might even be higher in sideroblastic anemia because that iron is not being utilized to form the hemoglobin. The total iron binding capacity, which roughly correlates with the transferrin production or the transferrin level, it is increased in iron deficiency anemia to compensate for the loss of iron. but in conditions of inflammation, it will be around normal, which is around 300 micrograms per deciliter. So this is the important differentiating point between iron deficiency and inflammatory iron anemia of chronic disease. The total iron binding capacity is always increased in iron deficiency and gives us a good differentiating point to differentiate the two. The percent saturation in iron deficiency, the percent saturation normally is around 25 to 50%. It goes to less than 10% in advanced iron deficiency, and it can also be decreased in inflammatory deficiency anemia. Whether in thalassemia, the percent saturation, and also in the sideroblastic anemia, the percent saturation is perfectly fine. So these are the differentiating points of the thalassemia or the sideroblastic anemia from the first two diseases, iron deficiency or inflammatory diseases. Finally, ferritin is the one which is very important. In the iron deficiency anemia, the ferritin levels are as low as 15 micrograms per deciliter. But in inflammatory condition and in thalassemia and sideroblastic anemia, the serum ferritin levels are either normal or high. So that ferritin gives us a most important marker of differentiating iron deficiency anemia from the other types of hypochromic microcytic anemias. And later on, we can eventually differentiate thalassemia from the sideroblastic anemia based on the blood smear picture, or via either doing our hemoglobin pattern or electrophoresis, because that is the only thing that will be abnormal for thalassemia. In iron deficiency anemia, the hemoglobin pattern or electrophoresis will be normal, similar in inflammation. But in thalassemia, we will have an abnormal beta thalassemia chain, and it can be normal if we have an alpha thalassemia. That is a different topic of discussion of electrophoresis. So electrophoresis basically helps us in differentiating thalassemia from other causes of enormous microcytic hypochromic anemia. And in sideroblastic anemia, similarly, the hemoglobin patterns will be normal. So this chart gives us a good indicator of how we are going to stepwise differentiate all of these conditions. The important screening test is the ferritin level that differentiates the iron deficiency from the other disorders, and then based on the basic understanding of the iron handling of the body, we can infer the other conditions, for example, the total iron binding capacity or the serum iron or the ferritin or levels. Now let's move forward on how we are going to treat iron deficiency. In case of iron deficiency anemia, as it's very simple that we have to replace the iron. What are the various forms in which we can replace the iron? Red cell transfusion, or the transfusion of the packed RBCs, is basically reserved for very acute conditions. If there is acutely a large hemorrhage and the iron level has gone down very low up till, for example, the hemoglobin level has gone down up to 2 or 3, and the patient has a lot of difficulty in maintaining hemostasis or even difficulty in breathing, then we have to transfuse the iron to make up the iron level up till at least 7 to 8 hemoglobin milligrams per deciliter, and afterwards then we can replace it either with the help of an oral form. So the general cutoff level of transfusion is around 5 to 6 milligram per deciliter. If the hemoglobin level goes down below that threshold of around 5 to 6, then we might consider transfusing the RBCs. Anything above that, and if the patient is able to take the iron orally, we replace iron with the help of an oral iron therapy. There are various preparations, either in the form of iron polymaltose salt or ferrous sulfate. Iron can be given in the ferrous sulfate solution. The important thing to consider here is that iron should be taken on empty stomach before the food intake, because the enzymes in the food, the enzymes released as a response to the food, they can interfere with iron absorption. It requires an intact gut and the intact proximal duodenum. The acidity of the stomach should be intact. So if all of these factors are present and there is not any emergency or acute condition, then oral iron therapy is basically the mainstay of treatment. In certain patients, we can who are unable to tolerate the oral iron therapy, we can go for the parenteral iron therapy in the form of various forms of injection like Venofer and other types of injection. They are given in the parenteral form, and then initially they are started off slowly because certain people, they might have an allergic reaction to that parenteral therapy. So if we start an iron parenteral therapy and the patient starts wheezing or having chest congestion, then we stop it and we try to find an alternative way. So the important thing is that the oral iron therapy is generally the cornerstone of treatment. But if we have an acute problem or an acute emergency, then the RBC transfusion until the patient stabilizes. And if the patient is unable to take the oral iron, then we replace the oral iron by the parenteral therapy. This can be also given in the pregnant females near term if their iron level is not adequate. So this was all about the iron deficiency anemia in context of the hyperproliferative anemia. It was the most common type of anemia, and a thorough understanding of iron deficiency anemia is very important from the examination point of view along with your general practice, because you are going to see patients with iron deficiency anemia and you have to manage them promptly. Now let's briefly talk about the other hyperproliferative anemias. The list includes any anemia of inflammation, either a chronic or an acute anemia, anemia of chronic renal disease, endocrine and nutritional deficiencies, or any condition that leads to bone marrow damage. So these 4 conditions, along with the iron deficiency anemia, these 5 conditions are what come under the umbrella of hyperproliferative anemias. These are generally the anemias in which there is inadequate response of the bone marrow to the erythropoietin, which is produced by the kidney. Either there is an inadequate response to the erythropoietin, or there is inadequate production of erythropoietin. So it is basically an anemia of production, and which is evident by a decreased reticulocyte response, less than 2%, as I told you in the start. There are certain conditions in which we have a normocytic normochromic anemia with an adequate reticulocyte response. Those are the conditions in which we have certain hemolytic anemias, and that is another topic. So it is important to differentiate the normocytic or normochromic anemia based on the reticulocyte count. The reticulocyte response or the reticulocyte count, because reticulocytes are the initial RBCs which are being produced by the bone marrow. These are the RBCs which are initially thrown off in the circulation, and they take 1 day to mature and become mature RBCs. So the percentage of the reticulocytes in the blood plasma gives us a good indication of what is the bone marrow doing. Is the bone marrow working fine? In regard, if there is a 3 to 6 or greater percentage of reticulocyte count, then we can very easily infer that the bone marrow response is adequate. But if it is less than 2 to 2.5, that means that the bone marrow is not responding to the erythropoietin, or either there is an inefficient response, or there is insufficient amount of erythropoietin to stimulate the bone marrow. What happens in the acute and chronic inflammation anemia? Let's talk about the pathophysiology. Now, these conditions include any condition which has a long-term inflammatory response, because, for example, a cancer patient with inflammatory production, a myeloid patient, a long-standing inflammation or infection like tuberculosis or rheumatoid arthritis, immunologic diseases, systemic lupus erythematosus. Any of these conditions can lead to chronic inflammation. And what happens is, with chronic inflammation, we have the pro-inflammatory cytokines. These cytokines initially lead to increase in the hepcidin production from the liver. Hepcidin, as I told you, is basically keeps a check on the absorption of iron at the level of enterocytes. So whenever we have an increase in the hepcidin level, it leads to decreased absorption of iron from the enterocytes. The iron basically becomes locked in the enterocytes in the ferritin levels. So the serum ferritin level starts going up, but those levels are not being able to utilize by the transferrin, and so the overall serum iron body concentration or the transferrin level starts going down. This natural response of the pro-inflammatory cytokines is basically to keep that iron away in case of any chronic infection. For example, if you have a bacterial infection, that hepcidin basically is a bodyguard of the system, because it wants to keep the iron stores away from the invading bacteria. That's why it basically stores down, or you have a large store in a room which has a lot of iron, and the lock is hepcidin. So if we have an invader and we don't want, which is any infection, for example, a bacteria, and we don't want the bacteria or the invader to get access to that storage of our important reserves, be it money or anything else. So basically, the hepcidin locks down the room and provides and does not provide access to the invader. So that lockdown of iron in the form of enterocytes basically also depletes the overall iron integrity of the body, and it leads to a condition of iron deficiency. Overall, that leads to an anemia in the long run. So, along with this hepcidin increased production, there is a decreased proliferation of erythrocyte progenitor cells by the inflammatory cytokines like the interleukin 1s, TNF alpha. That also leads to an impaired erythropoiesis. And these inflammatory cytokines can also lead to an impaired erythropoietin release at the level of the kidneys. As we know that kidneys are the major organ that secrete the erythropoietin, which leads to stimulation of the bone marrow. And also, these inflammatory cytokines over a long period of time can lead to a shortened RBC survival. So these are all the different mechanisms with the help by which the inflammatory conditions lead to a state of anemia. Explaining this further, let's talk about what happens if we have a neoplasm or a bacterial infection. An inflammatory cytokine, for example, a TNF alpha is being produced. In case of rheumatoid arthritis, we might have interleukin 1 production. These lead to a decrease in the erythropoietin levels at the level of the kidney. So there is not enough erythropoietin to stimulate the bone marrow. Along with that, these produce interferon, and that interferon, be it interferon beta or interferon gamma in case of interleukin, it also leads to suppression of the bone marrow. So the bone marrow does not have an effective erythropoiesis. There is a suppression of erythropoiesis, and not enough RBCs are being produced, which is indicated by a decreased reticulocyte index in the plasma. These interferon can also act on the erythropoietin, and eventual result of all of this is a decreased production of RBCs, and which can, or a decreased concentration of hemoglobin, or a decreased RBC mass index, which is generally defined as an anemia. And we don't have enough hemoglobin to carry out the oxygen in the long term. This happens generally in a longer period of time, and very rarely in acute conditions. So if someone who has advanced malignancy or long-standing bacterial infection or long-standing, for example, tuberculosis infection or a rheumatoid arthritis which is not being controlled, that can lead to long-standing anemia of chronic disease. Now, another condition that leads to hyperproliferative anemia is a chronic kidney disease anemia. What happens in the kidney? The mechanism is almost the same. There is an increased hepcidin production, which leads to ferroportin downregulation at the level of the gut, and there is a decreased mobilization of iron stores from the intestine, similar to the anemia of chronic disease. But the most important mechanism by which the iron deficiency anemia occurs in a chronic kidney disease patient is a decreased production of erythropoietin. Erythropoietin basically is a stimulant of bone marrow erythropoiesis. So it is being produced by the interstitial cells in the peritubular capillary bed of the renal cortex. So any abnormality of kidney, especially if it is long term, for example, in someone who has chronic renal failure secondary to diabetes or hypertension, or someone who has a myeloid kidney or chronic cystic disease of the kidney, it can lead to a decreased production of erythropoietin, and which in turn leads to downregulation of erythropoiesis, and long term leads to depletion of the RBC's mass. Transferrin generally, initially it is fine, but eventually it starts going down in these patients. The iron transferrin is basically the thing or the protein that carries the iron, the bone marrow, and at the transferrin receptor. The erythropoietin is taken up by the erythropoietin receptors, and eventually these interact and lead to erythropoiesis. So all of these steps go down in a patient with chronic kidney disease. What are certain conditions of the kidney that can lead to anemia? Hemolytic uremic syndrome. In hemolytic uremic syndrome, apart from the kidney unable to produce the erythropoietin, there is also hemolysis. So the picture becomes more bleak, and eventually by the combined mechanism of hemolysis and decreased erythropoietin production, there is an anemia development. Similarly, long-standing polycystic kidney disease or a myeloma or a diabetic kidney can lead to an erythropoietin deficiency, and eventually it leads to ineffective erythropoiesis. Generally, it leads to a microcytic, or generally it leads to a normochromic normocytic anemia initially, but if it is long term, it can also transform, just like the iron deficiency, into a microcytic hypochromic anemia. Now let's talk about what are the various hypometabolic states in which we can have anemia. The important ones are if we have any nutritional deficiency, for example, any caloric deficiency like in patients with kwashiorkor or marasmus. If we have a disturbance in the pituitary hormone production, for example, if we have a disturbance in the thyroid hormone production or glucocorticoid production, and Addison's disease, because hormone regulation is very important for the overall hemostasis of the body. These can all lead to a decreased erythropoietin production at the level of the kidney, which can eventually lead to an anemic state. An important mention here is anemia of the liver disease. Just like any other the other hypometabolic states or other chronic inflammatory diseases, long-standing liver disease, be it hepatic cirrhosis or because of any cause, it can lead to eventually, by different mechanism with the help of inflammatory cytokines, eventually it can lead to decreased production of erythropoietin at the level of the kidney, and long term it leads to liver anemia in a hepatic disease or a liver disease patient. Here we have a liver parenchymal production histopathology slide, and here you can see that the iron is being locked, and this yellow granules are basically the old RBCs which might be present here, or the old or the old cells of the liver hepatic parenchyma, which shows an inefficient response of the iron in the plasma. So let's talk about how we are going to treat these hyperproliferative anemias. The major mechanism is transfusion. If we don't have the oral access, either the oral access, or if we have certain emergency, for example, if we want to acutely get rid of the iron anemic state, the anemic state is very much advanced in patients, the hemoglobin levels are as low as 2 to 3 milligrams per deciliter, and the patient is unable to breathe or perform the activities of daily life, then we have to transfuse the hemoglobin either in the form of RBCs or whole blood to compensate for that hemoglobin loss. And eventually we might have to replace erythropoietin in patients. Erythropoietin is available in various forms, either in the form of erythropoietin alpha. There has been an erythropoietin abuse by the certain athletes as well, which comes under the doping charges. So that's why, because erythropoietin leads to stimulation of the bone marrow. So that is the major thing which we have to replace if we have an anemia of chronic disease or long-standing inflammation. So erythropoietin replacement and on the long-term basis and acutely we might have to transfuse the blood to compensate for the loss of iron. And similarly, when we are giving erythropoietin to the patients, we also have to give iron, so that if there is any concurrent iron deficiency, or the iron levels basically keep up with the erythropoietin production of the erythrocytes. So with that, we complete our discussion of the hyperproliferative anemias. Iron deficiency anemia is the major player here, and we talked about iron deficiency anemia in great details, and then later on we touched about the other types of hyperproliferative anemias. I hope you have learned something new from this lecture, and I'll see you in another lecture. Thank you for watching sqadia.com.